Well, welcome back, everyone. It's so exciting to see the energy in the room, and we will have more time at lunch for conversation and meeting each other. It's my great privilege to start off introducing our panel on pharmacoequity, achieving pharmacoequity, the vital role of deprescribing. I'm really pleased to get to introduce the moderator for this session. Dr. Utibe Essayan from UCLA is an assistant professor of medicine in general internal medicine and health services research. He is associate vice chair of medicine for equity, diversity, and inclusion, and is an investigator in the Center for the Study of Healthcare Innovation, Implementation, and Policy at the Greater Los Angeles VA. Dr. Essayan's research focuses on racial and ethnic disparities in the use of novel medications and technologies, especially for treating heart diseases. In 2021, he coined the term pharmacoequity to describe the goal of ensuring that everyone, regardless of race or social class, has access to life-saving medicine. We're so glad to welcome you here today, Dr. Essayan.
All right, good morning, everyone. So thank you so much for that introduction. Really excited to be here and to see so many friends in the audience as well. Boston is a special place where I spent some dark residency times, but at least things are brighter now. So as Cynthia mentioned, the title of our session, which I get to share the stage with our amazing expert panelists today, is Achieving Pharmacoequity, the Vital Role of Deprescribing. And I'm hoping in my brief time before we get to hear from our experts to share two brief objectives: introduce you to the term pharmacoequity and try to convince everyone that the work that you all do in deprescribing is actually really critical to achieving this goal. So some research funding, but otherwise no disclosures. So Cynthia already mentioned this, but this is what pharmacoequity is. It's ensuring, again, that everyone, regardless of race, ethnicity, socioeconomic status, has affordable access to the highest quality of therapies. And in the middle of 2021, in the midst of the disparities that we're seeing with COVID, both with outcomes, but also with access to vaccines and access to treatments, Dr. Stacy Ducedzino, Wally Gilad, and myself came up with this idea, kind of describing this goal. And it's a goal that we argued needs to be achieved across all aspects of the therapeutic continuum. I didn't have all the Ds that Dr. Chowdhury had earlier, but from developing drugs, testing drugs, prescribing, patients actually receiving them, and continually and safely adhering to them. And personally, I came to this work when I was a resident, just a few blocks or miles away. I was a primary care resident in Chelsea, Massachusetts. That's where I met Mr. C, a 67-year-old gentleman in my primary care clinic. He had several medical comorbidities, hypertension disorder, and one evening he showed up to the emergency department with slurred speech and was found to have a stroke. During his hospitalization, they eventually learned that he had atrial fibrillation and irregular heart rhythm, which increases one's risk of stroke. And when he was getting ready for discharge, they placed him on a medication to help prevent future strokes. They placed him on warfarin. Warfarin was discovered in the 1960s, really has been on De Beers criteria probably since the beginning of time because of how challenging it is to take, its complexities with medication adherence, et cetera. And this is at the time when there was a newer class of stroke-reducing medications, direct oral anticoagulants or DOACs available. And that really has become my work over the last several years. It's through Mr. C and others like him, studying racial disparities in access to stroke-reducing therapies. Why was Mr. C placed on warfarin versus the newer direct oral anticoagulant therapies? And we've seen in several studies over the last 7 years that this is pretty common, actually, that regardless of risk of stroke, so on the left side of the graph there, you see patients with low risks of stroke versus on the right side, black patients tend to be more likely placed on warfarin, which in many cases is an appropriate therapy compared to white patients. And so this idea around ensuring that patients are not receiving inappropriate medications is, of course, the crux of what all of you do in the room. Been gaining a lot of traction outside of our research space and the lay media as well. There's also been this new interest in understanding the connection between pharmacoequity and deprescribing. And so what do we know in this space so far? So I'm going to share 3 studies. I think there's a couple of the authors in the room, so please humor me as I share a little bit of your work and tell me where I described it wrong. So the first of these studies is examining polypharmacy. I think Josh is here somewhere, though I didn't get to see him already. In this case, is examining patients who are chronically on opioids and benzodiazepines. And this analysis, the researchers found that Black race was actually associated with a reduced odds of being prescribed benzodiazepines and chronic opioids compared to white patients. It's the only factor on this long list here that reached statistical significance. I think that's something important to think about. So when thinking about polypharmacy, this analysis showed that Black race is actually quote-unquote protective. In the second study, we're looking at potentially inappropriate medications. So this study came from the REGARDS study, a study based in the southeastern part of the country. And the researchers were looking at receipt of these potentially inappropriate medications. And they found about 87% of patients over age 65 were on these therapies. And really found some interesting findings, as I highlight on the right there, where Black males were significantly more likely than white males to be prescribed these potentially inappropriate medications. Individuals living in with low incomes, about less than $20,000 a year, had about a 26% higher odds of being prescribed these therapies compared to high-income individuals. And those with low education, less than high school, about 31% lower odds. So again, we have a bit of a mixed finding from our first study here as we're looking and seeing that Black race and lower socioeconomic status seems to be associated with higher use of inappropriate meds. And the last study I'll share is looking at psychotropic medications. And this study used MEPS data to try and examine how frequently these psychotropic medications were prescribed in older adults, benzodiazepines, TCAs, and even non-benzo psychotropic medications. Again, previous studies had kind of shown these mixed findings about racial and ethnic disparities in the use of such prescribing. And in this analysis, they found that Hispanic individuals, noted in the gray line, had about a 22% higher odds compared to white individuals of being prescribed psychotropic medications, these individuals who are older adults. And there's no difference observed between Black and white patients. So over these 3 studies, we've really seen some mixed findings. And I think while we have clarity around a framework for achieving pharmacoequity, this ABC framework that my colleagues and I have shared around improving access, eliminating bias, and reducing the cost of prescriptions, with quality kind of overseeing this frame, we don't quite have one for deprescribing equity. And I think that's still a black box, and it's what we're hoping to spend the next, I think we still have about 45 minutes or so talking about today. And I don't get to share all that by myself. I get to share it with my colleagues today, so I'm gonna introduce our panelists. Not in order of presentation, unfortunately, but it's gonna be okay. I'll first present Dr. Hyunjin No, who's an assistant professor of social work at the University of Alabama and a scholar in the Deep South Resource Center for Minority Aging Research. She's a social worker whose research focuses on deprescribing and non-pharmacological pain management along chronically ill adults, older adults. And she, of course, is a US Deprescribing Research Network Pilot Awardee. Then we're gonna, before her, we'll hear from Dr. Delon Canterbury, who I think you're gonna have to tell me how to pronounce the geriatrics acronym, but he's president and CEO. He's also based at the University of North Carolina, Chapel Hill. He is a US Deprescribing Research Network Collaboration Grant awardee for his efforts in improving medication use and deprescribing among faith-based communities in North Carolina. And to start us off, we're gonna hear from Dr. Nav Prasad, who's an associate professor in the Department of Family and Community Medicine at the University of Toronto, go Canada. He also serves as Canada Research Chair in Health Justice and is a staff physician at St. Michael's Hospital, and has done extensive research on applying a health equity and justice lens to improving access to essential meds in Canada. So without further ado, Dr. Prasad.
Thank you so much. So great to be part of a panel like this on equity in a great meeting like this on deprescribing. In most countries, the rate of cost-related non-adherence or not taking a medication as instructed due to the cost is lower than 5%. In Canada, the rate is above 10%, just like it is in the United States, partly because medicines are excluded from our publicly funded healthcare system. In Canada, access to medicines is governed by a racist and sexist public policy, where for most people, access to medicines depends on employment and private insurance. So factory workers, taxi drivers, food servers, musicians would all be examples of people who might be unable to afford medications by paying out of pocket and who in general would not have access to private insurance. We conducted a randomized control trial of 786 people who reported not taking a medication as instructed due to the cost in the last 12 months. These were individuals recruited from primary care sites in Ontario. And they were randomized either to continue with their usual poor access to medicines or free access to a list of around 130 essential medicines. As expected, over 3 years of the study, we found adherence was better. People were more likely to take medicines if they had free access. We also found improvements in some secondary health outcomes and a fairly substantial reduction in total health care costs of savings of more than $1,000 per patient per year over 3 years, the largest portion of that cost being related to hospital admissions. Somewhat unexpectedly, or maybe even paradoxically, although people were taking more medicines and were prescribed more medicines, we found a reduction in potentially inappropriate prescribing of medicines. And part of the reason for that reduction in potentially inappropriate prescribing may have been because the intervention involved setting up a pharmacy where the dispensing pharmacist had access to the electronic health record and could communicate with prescribers directly. But we think another part of the reason was because of the short list of carefully selected medicines. And there are examples and evidence from other jurisdictions, including the United States Veterans Administration, that suggest prescribing from a short list of medicines can avoid potentially inappropriate prescriptions, partly because both clinicians and trainees tend to prescribe from a short list of medicines that they may create themselves, even when they're left to their own devices, and any medicine can be prescribed. There are some examples that can help illustrate why this happens. One simple one is a very commonly prescribed medication in Canada is Docusate. It's known to be an ineffective treatment for constipation, and yet it would be among the most commonly prescribed medications in some long-term care facilities and in some acute care hospitals. So this medication obviously was not included in the short list of essential medicines, whereas effective treatments are. Providing free access to treatments can shift prescribing, for example, from warfarin to DOACs, which can be safer when used appropriately. And we also exclude from the list other medications such as certain treatments for overactive bladder, and instead have processes for encouraging non-pharmacological approaches to medications with a small degree of effectiveness. And I think part of the findings from our project would suggest that although a large portion of the reductions in hospital admissions was related to better access to medicine, so people taking treatments for high blood pressure or diabetes, some of those admissions were avoided due to avoiding potentially inappropriate prescribing. Short lists of medicines are not a magic bullet. These lists can grow over time for good reasons when new treatments become available, but also due to lobbying, which can sometimes increase the likelihood of inappropriate prescribing. Of course, highly effective medicines can be prescribed in situations that are more harmful than helpful. Examples would be medications like gabapentin or pregabalin, which in some studies are more likely to be prescribed inappropriately than appropriately, even though they are effective treatments. In Canada, like in the United States, we're experiencing an opioid crisis that was driven by a vast overprescribing of long-acting opioid medications like OxyContin in the 1990s and early 2000s. And there's little impetus to remove medicines from these short lists. So clinicians are keen to suggest changes or additions to the list. Likewise, our patients. Pharmaceutical companies are often applying pressure for medicines to be added. But on the other hand, there's not usually much behind suggestions to remove medicines for lists. So there does need to be some active surveillance of lists to ensure that they are updated appropriately. Before I wrap up, I'll just share a story and then some additional Canadian content. I think probably, I'm going to put in the feedback, there's too much Canadian content in this meeting so far. And I'm cognizant of that, and I know that nobody here cares about what's going on in Canada, not even the small number of Canadians here. So I'll be brief on that point. But first I'll share a story. So I was recently meeting with one of my patients in my primary care clinic who's in his late 70s, and we were talking about de-intensifying his antihypertensive regime because his blood pressure was going too low. And he said, I arrived here in Canada as a refugee, and at the time could hardly afford food. Medicines, being able to pay for medicines was a luxury that we couldn't even think about. He then created a business, a contractor business, that became successful, able to afford necessities like medicines. And then when he reached the age of 65, he got to the point where medicines, for the most part, are publicly funded. So for older adults, medicines are mostly publicly funded in Canada. And so he was saying, so now that medicines are publicly funded for me, you're saying I should stop taking them. And so I give that example because someone's experience of the deprescribing process can be different based on their experiences. And I mentioned racism and sexism before, and we know that there's discrimination within the healthcare system. So I think we have to think about how to implement deprescribing when it comes to people who've experienced disadvantages or discrimination within the healthcare system. In March of 2024, a bill was tabled in the House of Parliament in that country you don't want to hear more about. And it is supposed to publicly fund access to diabetes treatments and contraceptives in Canada in the coming months. And the bill also mentions creating a short list of medicines that will be publicly funded for everyone. So there's hope that we can, at the same time, promote access to medicines and appropriate prescribing and use of medicines. And so I think for everyone, if we're thinking about improving access to care, we need to keep in mind, as we are moving forward with deprescribing, keep in mind that access to medicines is a human right, and we should frame things positively in terms of improving access to appropriately prescribed medicines for everyone. Thank you.
Good morning, everyone. It's awesome to be here. Thank you to Esten, Michael Steinman, and team for allowing me to be here today on this wonderful panel with these esteemed colleagues. So we'll discuss deprescribing in educational and clinical intervention for community-dwelling Black adults with multiple chronic conditions in faith-based communities, using comprehensive medication management and the Vione model. So yes, a mouthful, but indeed still a significant topic today. So for those who may not be aware of the Vione model, this came from the VA and their methodology and framework to implement deprescribing with some of their veterans. And so this study, which started around 2016, showed on average about 2.5 medications getting stopped within the VA health system. And they used a dyad of pharmacists and pre-CPs within the setting. And what started as a small idea in Arkansas has now burgeoned into an innovative, worldwide, and highly accredited methodology for putting deprescribing into place. It's recently won accolades from the International Hospital Federation, and now we're seeing models of this in India, in Japan, and across the world. And the beauty about it is it's a low resource mnemonic that we can use as patients, as well as caregivers and patients, in putting this into play. Additionally, we have seen since inception about $110 million in cost avoidance in de-prescribing some of these medications. And on average, seeing about 0.3 less beers, meds, criteria drugs in patient profiles. So Dr. Sarah Bhattar, lead geriatrician at the VIO methodology, became a close friend in my work in publicly speaking about de-prescribing and using it from the community angle, community-based angle, in empowering our caregivers and our clinicians to date. All right. So some key questions and outcomes we are looking to empower some of our community stakeholders in partnership with, we be remiss not to mention, Duke HEAL, which is the Health Equity and Advocates Liaison, as well as Duke Clinical Translational Science Institute, as I am based in Durham. And so in this partnership, which started from me talking about COVID back in 2020 and getting involved in the community and empowering people and dispelling some of the common myths, I was able to share what your own geriatric pharmacist can do in your community. And little did I realize how much speaking on these town halls and panels would become a beautiful relationship with synergies among faith-based communities in Durham, along with the researchers we have at UNC and Duke. So that being said, we decided, hey, why not pilot something about empowering people on de-prescribing? Like, what does this mean? Let's make it a commonly used household phrase. And from our partnerships in dispelling COVID myths, out became this wonderful opportunity to put de-prescribing into primarily Black community faith-based churches and having the leadership and advocacy of their parishioners and leaders spearhead this with their community members. So, what are the outcomes of this project? We're looking to see if we can empower people with actionable next steps to drive de-prescribing conversations with their PCPs. We also want to talk about what are your general attitudes around this? Do you feel safe or comfortable? Does the messenger of de-prescribing matter in your terms of outcome of stopping a med or two? What are your general perceptions about your medications? Do you feel comfortable being able to drive a conversation about less or more, or dispel any myths that you may have or qualms? And in talking to these patients, we see time and time again these stories about graduating hospice or having a loved one who passed who was so over-medicated. And so using a framework of just giving people some common questions to ask, which come from the VIO methodology, is how we're putting this in a way to have people self-assess their med lists and then drive that conversation with their prescribers. So do you feel confident in discussing your medication concerns? What would de-prescribing look like for you within your churches? Could we make it a game? Could we make it a competition between different faith-based parishes? Can we count how many meds are taken off with a community setting? Like, let's make it a little bit more fun and a little bit more empathetic driven. That's the goal here. Additionally, who becomes your ambassadors or cheerleaders for de-prescribing? So the goal of this is to have ongoing educational focus groups or listening sessions where people can share some of their wins, share how they've been able to advocate for de-prescribing, what are some best methods, and really what are some barriers and enablers for success. So as mentioned, the VION model is defined by what meds are considered to be vital or life-sustaining for V. I for is it important for the quality of life. O is it optional. N, not indicated or the treatment may be complete. And lastly, does every medication have some type of indication? So getting people to have the mindset of asking, hey doc, is this vital and important for me to live for the rest of my life? How can we coach our patients to become their own cheerleaders for de-prescribing? That's the essential goal here. And so in using this mnemonic, we've seen people, over about 600,000 vets have been impacted. And again, a cost savings of about $160 million since about 2016. So also with the help of some of our colleagues in Australia, we'll be adopting the patient attitude towards de-prescribing survey, pre and post survey, to essentially triage what barriers or questions or comfortability patients may have as it comes to deprescribing. Another fun part of this project is we're also implementing pharmacogenomics. Yes, as a pharmacist, I love it. So of course I'm going to talk about that. So precision medicine is key here. And so in partnership with Virginia Commonwealth University, we're getting some pharmacogenomics kits donated for the people who get involved with some of these focus groups, looking for about 120 people to see if we can now track any actionable PGX-guided recommendations. Again, thank you to our partner for VCU in donating those efforts. And of course, lastly, the goal here, we're gonna have about 120 patients, but really it's giving people the platform to just share those stories. I cannot underestimate how much just being a listening ear and letting people share some of their hurdles, wins, or unfortunately barriers from the health system provides solace. And it's something that I think the trusted messenger that came from our COVID days has led to the growth in this partnership for this newer study. And I will let this also be known that there wasn't a teary-eyed in that room that was left from hearing and pitching this idea with parish leaders who've had reverends, pastors, all relate to wondering if these medications are right for me. So again, having that connection, having that room for empathy, and then giving people next step tools like, say, Empower brochures and other deprescribing toolkits can, again, foster the trusted relationships with their own pharmacist, sure, but also to show people that there are other ways to heal. So with that, I will thank you.
Good morning, everyone. I'm Hyunjin No from the School of Social Work at the University of Alabama. And I assume I may be the only social worker in the room. Any other social workers? And I'm very happy to be here. This is my first time in this annual meeting, and I'm very happy to be here as a social work researcher. So, as a health researcher in the field of social work, I focus on disparities in healthcare access and health outcomes. And for the last 12 years or so, my main interest area has been in end-of-life and palliative care. But recently, thanks to the support from US Deprescribing Network, I expanded my interest to include deprescribing among older adults with multimorbidity and chronic pain. So, in the past few years, I have conducted community-engaged research projects on the topic of experiences of pain management among community-dwelling older adults, particularly in rural regions of Alabama. And the projects involved in-depth interviews with community-dwelling older adults, their family, informal caregivers, and service providers. And as you can easily imagine, older adults in rural Alabama have a higher rate of comorbidity and multimorbidity than the rest of the country, almost always reporting cardiovascular and musculoskeletal diseases almost simultaneously, and also diabetes, and as a result, compromised mobility. Therefore, we have a high rate of polypharmacy among older adults in Alabama. For example, 83% of my current study sample is taking 5 or more medicines in comparison to 67% nationwide. And older adults that our team have interviewed so far showed great concerns about the use of their long-term medicines, such as side effects, addiction in case of pain medications, and financial burden as well. The vast majority of them are lower income and living in the lower income community with very lacking resources. So many of them are interested in alternative method, particularly in their pain management, but perceived barriers. And many of the barriers are imposed by the rurality of their environment in itself, where access to service providers, healthcare facility are very limited and got even worsened due to the closure of rural hospitals in recent years. And of course, the chronic shortage of pain specialists and alternative medicine providers in rural states. The uncertainty of resulting outcomes from deprescribing, maybe because of the lacking information or discussion with their doctors, was always a constant barrier in their discussions. And lack of transportation and limited coverage of non-pharmacological method by their health insurances were also commonly mentioned barriers, particularly among Black patients, older Black patients. Past and still most recent experiences of racism in healthcare settings, especially when they were in need of pain management, were seen as a substantial barrier to seeking care for effective pain management. And for both Black and white older adults, there is this lingering stigma around pain and pain medicine, particularly in the rural community, which served as an impediment to effective pain management. And we have to think about those kind of sentiment in the context of opioid pandemic, particularly affecting the rural states harder. So, building upon the findings of our prior studies, our team developed a mixed method study to examine the views of deprescribing and non-pharmacological pain management among community-dwelling older adults who have multiple chronic illnesses and chronic pain. And our team conducted surveys to examine socio-demographic and health factors associated with patient attitudes toward deprescribing and non-pharmacological pain management. And we also used in-depth interviews to explore their views. And I will discuss more details about this study and its findings in the showcase session this afternoon, so hang in there. I was very glad to hear that Dr. Chaudhry highlighted the status of current intervention efforts earlier this morning, and also Dr. Canterbury's wonderful example of community-based intervention. As a community-based social work researcher, my focus has been on the part of older adults and their family and informal caregivers. And one of the main implications from my current study was their need for information about the pros and cons of their current medications. And many of them even struggle to recount the current medication they were on. The range of medication, the number of medication that my sample was on was somewhere between 3 and 26. And this excludes all the vitamin and nutritional supplements they were taking on top of what they were prescribed by their doctors. So, and also the risks of polypharmacy, benefits of deprescribing, and safer alternative options, including non-pharmacological method for management of chronic pain. So these are all the potential areas to provide information on for our older adult community members. And also, interventions are needed to promote their self-efficacy in patient-doctor communication and decision-making for medications. There may be some generation differences. For older generations, doctors may hold even bigger authority figure, so they may not be totally comfortable to ask questions and seek clarification from doctors about their medication. And I see that kind of sentiment even stronger among older adults in Deep South in rural regions. So, and such efforts may be most effective when an interdisciplinary approach is made. For example, since I'm a social worker, we can contribute by serving as patient advocate and health navigator, and also facilitator of patient education, and also policy advocate to improve the health insurance coverage of non-pharmacological strategies. And regardless of the topic of the intervention, it's always recommended that the intervention is designed and implemented based on a partnership with community leaders and stakeholders, because they are the experts in the perceived barriers and potential strategies to overcome those barriers, including personalized and also culturally tailored approach in deep prescribing. Thank you.
That was really great. Thank you all so much for incredible conversation. Heard so much from each of you around like storytelling for our patients and our communities and how that can inform deep prescribing. Heard kind of a recurring theme around how perceptions for our communities and our patients really informs this, and really focusing in on the issues around inequities, around structural racism, et cetera. So we're going to dive in a little bit more. I think we're keeping great time, so I hope you're proud of us for that. And so I have lots of questions, have thoughts, ideas. I wrote notes. It's going to be great. Now, I think I'm going to start with you, if that's okay. You know, you mentioned lobbying in one of your slides, and I think when we think about the cost of medications, we brought it up around the equity side, but also you showed how affordable medications actually helps with reducing inappropriate medication prescribing. We think about like the government's role in helping to reduce that cost. But I'm curious what you think the drug maker's role should be, or should not be, in deep prescribing. How do we use the brilliant stories that we're all telling and that we experience in our clinical practice to actually change the work that they're doing, which is to continue to make money off of our patients and community?
Great question. I don't think we would expect pharmaceutical companies to change their main objective. I think when it comes to decisions such as about which medicine should be publicly funded or available to everyone, we'd expect there to be an independent, rigorous process. And I think part of that process should be that anyone should be allowed to suggest which medicine should be available, make suggestions about the situations a particular medicine should be used. But then there should be an independent process for determining what actually happened. So patients should be able to make suggestions, prescribers should be able to make suggestions, and of course pharmaceutical companies need to be able to make suggestions, partly because if they were not allowed to make suggestions, they could just indirectly make suggestions through other parties where they could pay to make suggestions. And then, on the other hand, we look at the evidence from clinical trials, evidence from observational studies, how medicines are actually used. There are certainly examples where medicines can be effective in clinical trials, but then when you look at the patient population that actually use, they're not helpful or mostly inappropriately prescribed. So we need an independent body that's making decisions apart from pharmaceutical companies who, and sometimes, we get the, again, like this is going to be like unwanted Canadian content, but we get the direct-to-consumer advertising that's actually not supposed to happen in Canada, but we get American TV stations in Canada, so people get the ads, and then they come in asking for medications that have been advertised, and I tell people, these big multinational companies from like scary countries like America, they're not only interested in your health. They are also interested in your money, and that's the way it's always going to be. So we have to make our decisions independently.
Yeah, no, it's a great segue to a question I have for you, Delon. I think, a patient might come into us and say, I saw this commercial for insert your favorite medication here, doc, like, can you prescribe this for me? And again, we were like, well, up to date says like I shouldn't, you're this age, you're this criteria, et cetera. And I think that potentially impacts trust, that potentially impacts a lot of the comfort that patients have with us. From your conversation, whether it's with the individuals, community members, parishes, et cetera, what are some of those keys you think to building that trust? I think this comes up in every conversation around equity. Well, you just got to fix the trust and we'll be able to fix this problem. But A, do you believe that to be true? And B, how do we actually do that?
Absolutely. It's a great question. And Again, I think I want to bring home the significance of having the space to listen and become a leader in empathetic-based care. Just having people share the floor from COVID myths to, am I going to get a chip inside me? It kind of relates to the same things we've been taught to think with general use of medicines. We think we need this to live. It's necessary in every instance. And so, yes, you are combating the system in a way, and how to retrain this type of thinking when it comes to medicine and healing and even alternative approaches to care. Is that better? Yeah. So, so yes, I lost my train of thought. So yeah.
You're telling us a little bit about trust, though. I think that's where
Yes.
you're going.
Yes, thank you. So building on that trust, really, a lot of what I do is, and what we do in aging is personal. There's some type of story. So leading with the story of your why and where you're coming from with the intervention, at least phrasing in a positive light and it being in the best interest. And of course, again, letting people just vent about some of the issues. You know, people don't always feel comfortable sharing about a side effect or even know it's a side effect. So to build that trust, yes, you, especially in our communities of color, you want someone who's a messenger who can relate to your background, to the hurdles, to what you see in medical racism, and have an understanding that you may not be able to always solve it, but you can at least appreciate that it's there. So leading with that, I think, is easy to just build that type of space and environment to cultivate a successful deprescribing intervention.
Yeah, that's helpful. Hyun-Jin, I think for your experience, you mentioned towards the end there that older adults may have this kind of hierarchical experience with providers where, you know, I just trust my doctor. We see this in the VA all the time. Like, whatever you say, doc, I'll do it. Whether that actually happens, it's unclear, but I think that is the perception. I'm curious if you think that we see that with younger adults also. I know a lot of work around pain treatment. We're seeing a lot of young veterans come in recent wars, and I think they're also experiencing challenges around deprescribing. How much does your work in older adults potentially reach that population too?
Good question. So the vast majority of my participants have been mostly older adults, age of at least over 60. But through my line of work, I got to interact with their caregivers who are still in their 30s and 40s. So access to actually seeing an MD is a very privileged experience in the part where I live. Of course, there are some urban areas in Alabama, but especially where I am in West Alabama, outside of the Tuscaloosa, Alabama, the vast majority of counties are very rural. So even the healthcare practitioners in their community are not necessarily MD, and they have to travel easily an hour and a half or 2 hours to see an MD. So just the exposure to communication with doctors is very rarely come by. So when they get the chance to actually get hold of doctor for, I don't know, 10 minutes max if they are lucky, whatever advice they get from their doctors, they are really ready to absorb. So they do not really have chance to critically evaluate the information they're getting from the doctor in the short period of the time. So in terms of the trust, I wouldn't say they're absorbing such information out of their respect or out of respect, because they really do not have the time and opportunity to build a rapport. But the culture is specific to the rural areas and in the South, the kind of symbolic position the doctor has, I think it has a lot to do with their perception of the advice that's coming from their doctor's office. But the problem is, because of lack of established relationship between the patient and doctor, they sometimes seek advice from multiple doctors over the course of their disease trajectory. So sometimes I hear a patient who's dealing with restless leg syndrome being prescribed on clonazepam, and then she is getting gabapentin from another doctor, totally unaware of the harmful interaction between the two. And it doesn't seem like the different doctors that she has seen has no way of knowing the other doctor's recommendation. It's not like they're sharing any electronic health record or anything. And in our community, oftentimes the doctors in urgent care serve as the primary care role as well. And then those doctors are very often rotate, and it's not like you can always see the doctor. So there is a lot of disconnect in terms of the kind of a medical regimen they are on, the decision making, and we do not have the platform to build a decision making process based on a trust or a long-term relationship. And that has a lot to do with the trust that you just mentioned, and that's the status and reality we are in.
Yeah.
And it applies both to older adults and young adults, going back to your question.
Yeah. No, that's huge. I mean, we're hearing, I hope you guys are taking notes, like future research ideas here, that like overlapping prescribing, I think, is a huge problem we all know, and how that differs or may differ by race and ethnicity, by rurality, by income status. I haven't seen any papers on that yet. I hear the NIA is going to fund that soon. But I think that would be a huge study to do. And I mentioned that because, on my last slide was we don't really have a framework for thinking about the deprescribing equity part of things. And so I'm hearing from you all that time is an issue, like literally more time with patients is critical, not just to make sure you're getting the right therapies, but also that we can have thoughtful conversations around deprescribing. We of course heard that racism is an issue, which is so hard to study. We have scales around discrimination in every day and in healthcare, but how do you actually capture racism in our observational studies is really challenging. I'm curious from you all, then I'll open up to the audience for questions. What other parts of that framework do you think we should be considering? What are some of the other barriers from making this an equitable process? Whoever wants to start.
Sure. I mean, I think just building off what you just said, I think access to health care is an important part of deprescribing. It takes more time to ensure that a medication is first appropriately prescribed and then deprescribed if necessary. And I think through the conversation so far, we've heard several examples of how trust is needed, and that trust is less likely to be present where access to care is poor, where people either can't physically access a primary care provider or another care provider, or something has happened in that relationship to cause distrust. The patient has experienced discrimination such as racism or sexism in the course of accessing healthcare. So I think that the access to care and trust is an important part of achieving equity through deprescribing.
Other thoughts from you all?
I would say with time, really, putting in the time to leave the floor to have frank conversations about perceptions of medicines, about long-term benefit, giving every medication a timeline, just kind of giving tools for clinicians to kind of spearhead this conversation. As we know, 92% or so of patients will agree with doctors' recommendations to deprescribe once they have that conversation getting, but we don't always have a way to help them kickstart that conversation or have it higher on the list. So when we can kind of ingratiate a different philosophy around good prescribing habits, which goes in tandem with good deprescribing, it makes the long-term downstream effects a bit more sustainable. So I think first there's of course provider education or NPs, PAs, et cetera, but there's also really empowering the caregiver with some type of basic framework. We have people who develop tons of frameworks, but are they caregiver specific? Are they patient friendly? Is it easy for me to understand as a 5th grade reading level? Having those barriers addressed intrinsic into the conversation will help with long-term benefits. So to me, it's culture of prescribing, of course, battling commercials on TV, sure, but again, reframing the dialogue from trusted messengers in the community, and that's why you need trusted community stakeholders along with the researchers and the health community networks, et cetera, to make it work.
And I also want to touch on the psychological aspect of it. So because I work with older adults, they've been on their high blood pressure medicine and high cholesterol medication or diabetes medication for years, if not decades. So it has been already normalized in their routine. Like as they just pop in some vitamin supplements, they would just pop in multiple medications. And so that kind of behavior has been normalized, especially when their doctor didn't really raise any concern about it, had an open communication with them. And I briefly mentioned earlier, but the issue of uncertainty. Even if they have a chance to talk about the potential risks of those medications they're on, if they are uncertain about what's going to come, if they make any changes to medical regimen, it's really hard to bring in any behavioral change because, for better or worse, it has been working for them. They're still alive. That's how they perceive. As far as they're alive, they're like, this must have some benefit. So I think the efforts to change their mindset, especially a medical regimen they are on for a very long time, I think it really takes some intentional conversation between the patient and the doctor, as well as between the caregiver and the doctor. So there is definitely systematic, but also this psychological aspect of it.
That's really great. Well, in a country where they're still alive differs a lot, where whether you live in the rural South or an urban neighborhood, whether you live in Roxbury or Back Bay, that matters a lot. So I appreciate you bringing that up. Questions from the audience? You guys are all listening to these brilliant panelists. Any thoughts or ideas brewing as we bring things to a close? Yeah.
Hi, everyone. Thanks so much for this great panel. It's certainly got me thinking a lot about new questions and ideas. So I'm also Dan Harris from Brown. My first question is actually related to this theme of intersectionality, actually, as you raised this, in that the experience of structural racism is different in different parts of the US and different parts of the world. And kind of how you see intersectional frameworks fitting into your framework here, and then how you'd recommend for us as researchers to integrate that into our research, both on primary data collection, but also like as a pharmacoepidemiologist myself who uses claims-based sources like that. So thank you.
Great question. Thoughts from the group?
He always asks great questions.
Yeah, I think that I can just start. I think that's really critical to the equity work. I think the classic, like New England Journal 2000 paper, heart attacks and who's more likely to get referred to cardiac catheterization versus not. Black women were the least likely to receive that potential intervention. So that intersection around race and sex, intersection around rurality and race, et cetera, all the various isms that we know to exist in our country, I think are really critical. So having that framework on top of an equity framework, I think is part of the job and needs to be done. Easier said than done when we get into some of these claims data analyses. How well is that data collected and reported? How small do the samples get when you're trying to understand why Asian women with atrial fibrillation in the VA, there's like 6 of them, aren't getting DOACs. And so going in with that framework to begin with, and I think as reviewers, editors, et cetera, showing grace when we realize the samples get small, I think is important too.
I totally agree. I'll just add one point. We did a study of clinical practice guideline panels and showed that most guideline panels don't include a racialized woman. So I would also suggest that when we're designing interventions, designing studies, providing guidance about clinical practice, we need to think about who's involved and take an intersectional lens there as well.
That's great. Dr. Keller.
Hi, Michelle Keller from the University of Southern California. One of the things that I was thinking about when you were discussing this idea of a framework for deprescribing and achieving pharmacoequity was this idea of social determinants of health, and to what extent is, for example, access to non-pharmacological treatments. So for example, I was thinking about with chronic pain, so for example, access to physical therapy, or for sleep, access to cognitive behavioral therapy. And I'm wondering to what extent you've seen kind of these types of, this incorporated either in your own research, to what extent can we measure, like how much is this affecting kind of our ability to deprescribe when folks don't have necessarily access to these other modalities?
Maybe I could mention a little bit to that. Thank you for raising the question. It has implication. Every determinant in that framework has something to do with the outcome, especially in pain management I'm seeing. So for example, the rural community that I work with, the only rural hospital they had for decades closed down a few years shortly before COVID hit, even before COVID hit, and it has a small swimming pool. That was the only swimming pool they had in their perimeter. It was not just for kids learning, taking swimming lessons, but it was for many of the older adults with arthritic pain to take non-medication based exercise routine, and that was gone. And every person that I asked to about, are you interested in taking something other than medication to deal with your lower back pain and your joint pain, and they 99% of the time they talked about the limited access to the exercise facilities like that. So we talk about, it is known on news that there is lack of representation for marginalized people in clinical trials. And I also want to talk about the geographical issues, the rural versus urban disparity as a huge social determinant of health. I see its impact greatly on pain management and its outcome. So even for white older adults in rural communities, they are experiencing pretty much the same kind of challenges as black older adults are experiencing in rural community, in urban communities. So I think as much attention is needed for racial disparity, but also this rural versus urban disparity is getting only bigger, especially with the closure of rural hospitals and the lack of service providers. We have this rural residence program fellowship at the University of Alabama. So they serve the rural community a year or two after their residency is over. But these older adults talk about, like, as soon as the fellowship is over, they are gone. Like, by the time they get to know these young fellows and start to, build some relationship and open up to talk about very sensitive issues such as palliative care or end of life, they are gone. So yes, absolutely, social determinants of health should be at the core of this discussion.
I agree fully. I'll just add, I think promoting access to non-pharmacological treatments that are free or publicly funded is one way to signal that deprescribing is not about cost-cutting to patients, not about saying, you're costing the government too much money, so we're trying to deprescribe this medicine, because we're saying we're concerned about your care. You have foot pain, you can see a chiropodist. You have overactive bladder, you can see a pelvic physio. So it's not about saving money. It's about improving your health.
All right, thanks, Michelle. One final question.
Yeah, my name is Helen from University of Wisconsin-Madison. I'm just wondering, when it comes to research in health equity, I feel representation matters. How can you encourage more people, minorities, to engage in deprescribing research?
That's a great question. I'll defer to Dr. Steinman and Dr. Boyd as well. Maybe there needs to be a minority supplement to the grant awardees. I'll put that little shout out there, shameless for sure. So it is funny, me and Delon, the first thing we noticed when we first came in was how we're, 2 of 3 black men in the room. And I think that's very common in many spaces that we are in. The research shows, not just for research purposes, but for clinical purposes, that diversity actually improves health outcomes. That's another great future study. Does diversity actually improve deprescribing outcomes? I don't think we have any data on that. So just throwing out future JAM-IM papers for you, Tim. So it's huge. I think there's a lot of work that we can do in diversifying both the health care as well as the research workforce.
Yeah. I agree. Maybe I'll just add, when we're talking about equity, talking about improving care, we're definitely talking about money. And so, when you're asking about, what can be done, I appreciate the call out on, directed funding towards sort of deprescribing research that's going to not just improve care, but help achieve health equity.
And to add another social worker perspective, borrowing my experience in end-of-life and palliative care, these minority groups who haven't been traditionally part of the clinical trials and interventions, they really need to hear from other community members who have the experience. That's where lay people, health navigators, and can come in, and they can be very helpful to lower the guard against any kind of like a health interventions, which can easily scare off many minority groups. But once they hear the experience from their neighbors or church congregation or their members from their local PTAs that they have a positive experience with the intervention or whatever clinical trial goes on, that is definitely the gateway for them to consider the opportunity and participate in whatever efforts you are pushing for.
Awesome. Well, another round of applause for our awesome panelists. And I think we'll transition to the next part of the meeting. Thanks so much.